Ya, Mbak. Selamat siang, Bapak Ibu. Selamat siang, Prof, Bapak Ibu.
Selamat siang.
Selamat siang, Romo.
Eh,
Kembali lagi di Rabuan Discussion Forum. Dan untuk Rabuan kali ini sedikit hybrid, jadi kita pembicara kita teramat istimewa pada siang hari ini, yang hadir juga di Yogyakarta saat ini, yaitu Prof. Willems. Izinkan saya untuk memperkenalkan terlebih dahulu, walaupun mungkin Prof. Bapak Ibu juga sudah mengenal Prof. Dik sebelumnya, karena beliau juga sudah sering datang ke Yogyakarta dan juga sering menjadi visiting professor di Universitas Gadjah Mada. Prof. Dik adalah seorang general practitioner, family physician with experience of 15 years and more, and he is Emeritus Professor of Medical Ethics at the Amsterdam University Medical Center, University of Amsterdam. He became professor since 2003. And then just recently retired, and now emeritus professor at the Amsterdam UMC. And Prof. Dick's research interest and supervision is usually for PhD students, and the topic is ethical aspects of genetics, ethics of big data research in medicine, palliative care and end-of-life issues, and also home care or self-management technology. Prof. Dick has been principal investigator and also researcher of numerous projects with national and European funding, and is an ethics advisor at EU-funded research projects. Until recently, he is also co-leader of the personalized medicine program within Amsterdam Public Health, within two large EU-funded studies in cardiology, or it is also called Escape NATE Profit, and he is leading the ethical and societal work packages. So he has so many publications that I cannot mention here, and also so many recent publications. The recent publications topic is around how do doctors differentiate between suicide and physician-assisted death, and also usability of the surprise question by nurses to identify 12-month mortality in hospitalized older patients, and also healthcare providers' views on the transition between hospital and primary care in patients in palliative phase. And currently, we are also involved in a research, my PhD project with Prof. Dick and also Bu Siwi, that is about ethical aspects of primary healthcare, so exploring it in Indonesia. And then Prof. Dick today will also discuss or present about ethics in primary healthcare. So floor is yours, Prof. Dick.
Okay. Selamat siang to all of you. And thank you very much from the Center of Bioethics and Humanities to invite me here to speak at your research symposium. That's really a great pleasure. So I'm really happy to be here. And so what I would like to do is to explain my view on ethical issues in primary healthcare. And most of what I'm going to tell is from experience as a general practitioner in primary care, but also from teaching to general practitioners in the Netherlands and elsewhere. So you might want to start maybe the PowerPoint. And I hope we can have some interaction with the audience. Obviously can interrupt. That's, it's always a bit difficult when you're talking to people who are somewhere else to have a good interaction. So I would really be very happy if you could interrupt me. You make me most happy if you interrupt me and ask me questions, or even say that you disagree. So please do interrupt, just start speaking. So we'll hear that you want to interrupt me. But now to begin with, I'd like to start with the first slide. I don't, if it doesn't work yet, I don't know. Should I direct it somewhere specific? Yes, that's it. Okay. So I'd like to start with by giving you a little bit of context of general practice and primary care in the Netherlands. And I always like to start with this map of Indonesia put over the map of Europe, so that you can see from which tiny bit of country I come from. The Netherlands is the bit of a dark part just above Borneo there. And so you see your country is so much larger that I always feel impressed if I'm here to speak about the things that we are doing in the Netherlands. So I'm really happy I can do that now. So we have a population of about 17 million, a bit more than 17.5 million now. And that's on a surface of 41 square kilometers. So it's quite densely populated, because you have in Indonesia, about 260 million on 2 million kilometers. So you see that the percentage, the distribution is a bit different. In Dutch healthcare, there's formally a central role for primary care and for the general practitioner. We now in the Netherlands have about 9,000 general practitioners, and about 50% now of them are female. And I think it's a bit more by now, because this is already 2 years ago. So I think it's a bit more now. And when you look at the number of GPs under 40 years, you even get 2/3 of females, and that will increase all the time, I think. So we have about 4,000 practices in the country, so 4,000 GP offices, and 70% of the patients see their GP at least once a year. And so that's a lot, but it's also 30% of patients who see their GP less than once a year. And some of them even don't know their GP. They're so healthy that they never need medical care. But on average, patients see their GP about 6 times per year. And so primary care consists of the GP, but also of community nurses, of health assistants, of social workers, and of physiotherapists. So this is just to sketch a little bit of background in the healthcare system. And the central role for the general practitioner is, in fact, that if a patient has a disease, the GP is the first person to see. So he has a sort of a role, and he can refer or he cannot refer the person to other institutions or other specialists. That's similar to the system in Indonesia, I think now. So the next slide, can I? Oh no, I'll do it myself. True. Just a little bit more about context. The Dutch population, just like here, I think now, I know now that you have that here as well, has an obligatory health insurance. So you have to be insured for healthcare, and that health insurance, and that's a bit different from here maybe, is provided by private insurance companies. So there is a basic package that they have to offer to everybody, and there are voluntary additional packages. So people can opt for, let's say, psychological help or for complementary medicine like herbal therapies and that kind of things. And in the Netherlands, general practitioners provide most of the care for the most common diseases, common and usually self-limiting diseases such as common colds or diarrhea, that kind of issues, and for many infections. Also, of course, for COVID infections the last couple of years. And they also provide most of the care for chronic patients. So people with a chronic disease, like people with diabetes or asthma or any other. And the last group I want to mention is that most of the palliative care patients too are taken care of by general practitioners. So I think that's all I had to say about context. This you can't read, but it's no use for you anyway, because it is in Dutch. But I'd like to say a little bit about the central values of primary care, because I think that's in fact really the ethical basis of a primary healthcare. And this is a sort of a schedule that, or a scheme that has been set up by the Dutch Association of Family Medicines, and it specifies the core values of primary care. And for your convenience, I've put them in English here. And in fact, there are 4 core ethical values behind primary care in Holland. The first one is that primary care is personalized care. So it is adapted to the personal values, the personal history, and the personal characteristics of patients. So it takes into account the things that patients find important, that they wish to do, and also things like, for instance, genetic characteristics of patients. So everything that's known about a patient is part of the personalized care of the general practitioner. And I think what's very important in these central values is that it is a trust-based relationship. So more, I think, than in specialist care, where patients usually don't see the specialist very often, the relationship with the general practitioner is usually more close, and it's more based on trust, on mutual trust. So, and I think trust is really one of the core values of primary care. So that's the first core thing, core value. The next one is that the GP is operating as a medical generalist. So the family physician and primary care in general is the first line for every health problem. So whether you have a pneumonia, or whether you have cancer, or whether you have an appendicitis or a heart attack, it's always going through primary care first. And I think one of the values that I want to mention, because I think it's a very important value in general practice, is that the medical doctor doesn't give too much care, so no unnecessary care interventions, but also not too little. So they provide what is necessary, but not more than what is necessary. And that's because we're all very afraid of adverse effects if you give too much care. So we really try to limit things to what is really necessary. And I have a few cases from that general practitioners told me about, and it's sometimes very difficult. It's a very difficult value to realize sometimes. So that's the medical generalist. That's the second value. The third value is that primary care should be continuous care. So it should be available 24 hours a day, 7 days a week. And that's what we have in the Netherlands. So the office, in fact, is never closed. In the night, of course, there There are services that guarantee the availability. Not every doctor can provide 24 hours personally, but continuous care is one of the core values. And it's also continuous in the sense that a patient in general will be able to see the same doctor every time again. So there's very little variation in the doctors they see. So that's in fact what's meant by the continuous character of primary care in the Netherlands. And the last value is what's called cooperative care. So GPs work together with both the medical specialist, with nurses, social workers, with spiritual care as well. And so that's one of the central things of GPs. Another central thing is that the GP works together with families. So usually the family doctor is the doctor of the whole family. So they treat both the children and the grandparents. Now, in modern societies, very often families are more dispersed. So the grandparents live in a different city or in a different village. So then it will be the core family, the parents and the children maybe. But usually families have one GP. So they work with the family. And that's also a central value. And so all the cases that I will tell you about have a relationship with these central values. Now, I've listed a few ethical issues that are, I think, quite specific for general medicine. Specific, and you don't find them so much or to the same extent in hospitals. You may find them, but they're maybe less important, because they are part of the core of general practice. And the list is about seven things, and I will have a few examples in every one of them. So, and I'll show you every time where I am. So in the next, let's say, 40 minutes or so, I'll try to give you examples of ethical issues in primary care in all these areas, and also maybe what we do with them. But I'd like to have your advice as well about that. So the first thing is that is about prevention and lifestyle issues, because one of the aims of general practice is, of course, to prevent disease, not only to treat it, but also to prevent disease. And as you all know, that nowadays most diseases in both developed and developing world are related to unhealthy lifestyles. And there's all kinds of sources for unhealthy lifestyles. But in the Netherlands, general practitioners are usually playing quite a central role in lifestyle advice, in giving people with overweight, or people who are still smoking, or people who are taking too much alcohol. That's fortunately a problem that you have a bit less here. But all these patients are seeing their GP and are usually getting advice from their GP. And one of the ethical questions that doctors frequently bring in if we talk about ethics in general practice is, if you see an obese patient and you want to give that person lifestyle advice, and the next time that person returns to see you and he's even more obese, and the next time he's even more obese, and you keep telling him that that's not a good idea because it will lead finally to health problems, then the question is, how much pressure can you put on wanting to change the lifestyle of that patient? So one of the questions sometimes we have is, can you put financial sanctions for smokers or for obese people or for people who take other risks? Is it ethical to, for instance, have higher insurance premiums if you're not living a healthy life? Or is it ethical to make them pay more for the healthcare? And some people also say, is it ethical to let them pay for the consequences of their unhealthy lifestyle? So So if they develop, let's say, cardiac disease because of smoking, would it be ethical to pay for the consequence? And these are issues that general practitioners bring up. Sometimes they also ask, is it ethical to refuse a patient because he never listens to your advice? So those questions come up, and I think generally we don't think these things are ethical. So we do think that a lifestyle is in the end the individual choice of a patient. And you can try to help someone, you can try to persuade someone to have a more healthy lifestyle, but I don't think you can, and we don't think in general, and that's usually the outcome of a discussion about these issues, that patients can be held responsible for the consequences of their lifestyle by the doctor. And even higher insurance premiums for many GPs are not acceptable, also because many of the people with a bad health lifestyle, an unhealthy lifestyle, are in the poorer layers of the population. So they usually don't have that much money. So you in fact, you punish them 2 times for their unhealthy lifestyle. They get diseases and they also have to pay more. So that for almost everybody is not an ethical thing to do. There is an interesting discussion also among GPs is whether you can nudge people to behave healthily. I don't know if all of you know what the term nudging means. Nudging means that you, these are examples of nudging. So you can say that you see the big elephant giving a little push to the small elephant, a very prudent push. So that's in fact what the nudgers do. And you see the example in the middle. One of the things that is healthier than is healthy to do is walk stairs and not take escalators. So it's better to walk the stairs because that gives you a bit of exercise, and it's a good way to remain healthy. So what they did in Sweden in the subway is that they turned the staircase into a piano, and you see the piano keys. So, and you see the people playing there because they can play tunes while walking on the staircase, and that's a way of nudging. So you nudge people into doing something healthy because they like it as well. And sometimes nudging is a bit more intrusive. For instance, when you make elevators almost make it very difficult to find elevators. That's what they do in modern buildings. Usually the elevators are very hard to find. And so they make staircases attractive, or they make elevators very hard to find. Or what you also can do is turning smokers into a sort of a pariahs. So make them into a group that nobody wants to belong to. Make unhealthy food very difficult to find. And the ethical question that many doctors and many patients also ask is, where does it turn into manipulation? So how much freedom do you want? Do you keep for patients? How much autonomy do they have to take an elevator or to eat what they find, what they like? And I think that you should be quite careful with nudging and not turn it into manipulation. And obviously we all have nudging in our pockets all the time these days. When you look at all the apps that you can have on your phone for, let's say, for the amount of movement that you have, or how much you eat and what you eat. So this is really something something important now. I'm going to, it will take too much time to do all this. I want to jump to the family issue a bit more. So, this is about a screening test. And as I told to you, usually the family is the unit of care for primary care. And this is an example of a gentleman who had who ordered a total genome sequencing over the internet. You can do that easily these days. So you just go on the internet. It's easy, but it's quite costly. I think it's about 1.5 million rupiahs, but many people can pay that. Is that 1.5 million? 100 euros? Yes, it is, I think. Yeah. So it's quite expensive, but people do that sometimes. And also in this case, it was partly reimbursed by his employer. I think I would like to raise an ethical question there already, because the partly reimbursement made it very easy to do this for this gentleman. And we will see in the rest of the case that it's not all very nice, this kind of genomic tests. So the results of the test revealed that this gentleman had a 35% chance of a myocardial infarction in the next 10 years, because he had a genetic predisposition for that, and some 25% chance of getting some form of unspecified cancer. So he will need a yearly screening for different types of cancer because they don't know what he will get. And that, in fact, worries him very much. So the family here is very upset because of the worries they have for them. So they say to the general practitioner that it should have been a common decision between the gentleman and the family, because this also concerns the family. They may have the same genes as he has, especially his children, of course. So that's a way in which the GP may have to deal with the family, because much of what the GP does in terms of investigation, especially genetic investigation, also has consequences for the family. So I think what a GP in this case should have done is to say to this gentleman that, and to explain to him that if he would do that, it would be something that's also could have consequences for his family as well. So that maybe he should, before doing the test, should be first talking about the test with them. So they would be able to give their views and to be involved in the decision to do the testing. And obviously, the GP is very much involved here because he has to organize the rest of the investigation that this gentleman has to undergo. So that's the first case that a GP during one of these sessions brought in about prevention and lifestyle issues. So I'd like to go to the next one after a little bit of water, maybe. And that's about informed consent and referral. I think informed consent, like everywhere in healthcare, is one of the basic issues in family medicine as well. So, but sometimes it's difficult, and sometimes there are ethical issues related to informed consent. And the Dutch health law specifies that the professional should give the patient the information that she needs or he needs to take a responsible decision about her health or his health. So all the information that a patient needs to take a responsible decision should be given. Also, not more than that. I mean, you're not obliged to give information that will not help the patient to decide. And there are two exceptions to that rule in Dutch law. And so the first one is that there is a right not to know, according to Dutch law. So patients can say, I don't want to know about some disease that I may have, or some genetic predisposition that I have, because I would be too burdened by that knowledge. I simply don't want to know. That's the right not to know. It has an exception, but that's not very important. And the other exception is when information itself could be harmful. And that sometimes occurs in general practice as well. And I want to show you an example of a patient who came to see his GP for complaints, and who was asking for a referral. And then the GP was very hesitant. So this is about colonoscopy. And the patient had complaints of intestinal bleeding. So he had the black stools, and he was also feeling not very well. So those complaints were there. And so normally he would need a referral for colonoscopy. But this patient has a trust relationship with his GP, but with almost no other doctor, because he's really afraid of doctors. He's always very anxious that something bad will be happening, or that they will make mistakes or things like that. So he's really very anxious. And he's also hypochondriac. So every little complaints, according to him, means the worst. He's always thinking about the worst case scenario. It's always the beginning of cancer or something else. Now, usually the GP explains to the patient what will happen during colonoscopy. And they also will explain that there is a small risk of intestinal perforation. It's a small risk, but that's a side effect of colonoscopy that you usually have to explain, because you have to tell the person that there is a small chance of a bleeding or a perforation, and that it sometimes needs surgery to be cured. Not always, but sometimes needs surgery. So now, because this patient was very fearful, the GP asked the group of GPs that we were having, the group that were talking about ethical issues. This GP said, if I'm going to tell him about the risk of colonoscopy, I'm afraid that he will be refused to be referred. So he will say, I'm not going there because I'm too anxious. And in fact, the GP said, what will I do if he asks me if there's any risk? Because he said, if I'm going to tell him that there's a risk, he will not do it. And in fact, I think he has to have the colonoscopy, because he may very well have cancer, and then it can be treated. So what would you, maybe the audience on the other end of the camera could think about this issue, who maybe someone would say something about it. Should you tell this risk to this patient, or should you take into account his fears and not tell it? So should you give completely informed consent, or should you not give the information and refer him and say there's no serious side effects?
Silakan Prof, Bapak Ibu, apabila ingin menanggapi. Jadi pertanyaannya adalah apakah sebagai dokter akan memberitahu tentang risiko tersebut atau tidak? Silakan apabila ada yang ingin berpendapat. So the question was to tell about the risk?
Yes.
Or not?
Yeah, maybe you can explain that in Indonesian.
I already.
Yeah, oh, you already did. Yeah.
Jadi apakah
yes, but knowing that the patient is so afraid that if you tell about the risk, he may decide not to do the investigation.
Ya, jadi karena pasien ini hipokondria, jadi dia memiliki kekhawatiran yang luar biasa. Kemudian dokter yang merawat juga berencana untuk tidak memberitahu gitu, mungkin mengenai resiko yang 1% bahwa jika dilakukan kolonoskopi bisa terjadi bleeding. Resiko tersebut, meskipun demikian, resiko tersebut bisa diobati atau diatasi dengan operasi. Kemudian pertanyaannya menjadi bagaimana jika pasien ini menanyakan resikonya apa? Apa yang harus dilakukan dokter yang menangani? Apakah akan diberitahu atau lebih baik tidak? Silahkan, monggo Bapak Ibu apabila memiliki pendapat.
Ya, saya maaf.
Halo. Halo.
Ya, saya bisa nanggapin. Halo.
Halo.
Ya, silahkan dokter.
Yes, we hear you. Yeah.
Yeah. Okay. First, I prefer to deliver the message because even there is informed consent, but anyway, the risk is so little. I mean, it's 1%. Anyway, if she will perform the genetic test, that will be not the real. Actually, it's a susceptibility to have a cancer, but it's not affected yet.
No.
It would be very scary for her or him, for him to face that in the future. But they could not be. That is another. So we have so-called genetic pre-genetic test counseling. So for this, I prefer to inform because the risk is so clear. Only 1%, and we have to perform until we can do the further procedure.
Okay, thank you very much. Thank you. Thank you. So I'll come back. Maybe there's someone else. Also, there was a remark in the chat. That's a very good way to respond if you want. Maybe can you show the chats, or is that possible at all? That would be nice to see that. Yes, thank you. So how's so maybe I think that's a very good remark too, that it depends on the question how the hospital will deal with very fearful and hypochondriatic patients. So I think that will be something that plays a role. And then there's two remarks in Indonesian that I can't read that quickly. Sibi, could you read that, you think? Pratiwi, I'm sorry.
I cannot. Oh, I think, no, this is just the announcement.
Oh, something else.
Yeah.
Ah, that's from, yes, I see.
From,
oh, that's later, that's earlier.
Yeah.
Okay, thank you. So you may return to the presentation again if you want. So, thank you very much for your comment. I think most of the doctors that we had in our talk were also inclined to tell about the risk, because they say that if I don't tell it now, they will tell probably in the hospital, and then that will undermine the trust the patient has in me, especially if I say there's no risk, and then in the hospital, they will be talking about the risk. He will have no trust in me. And in fact, the GP was the only doctor that he trusted. So the physicians usually find it very important to maintain the trust that patients have. So they have to be trustworthy. And I think that lying or not even telling the truth may be something that undermines the trust so much that you would always have to do it. Even if there's a risk that he will not go and see the doctors for a colonoscopy. So I think if you balance the two, so you balance between his right to be informed on the one hand and the need of the investigation on the other hand, I think the right to be informed is the most important here, even if it would lead to not going there, because then as a GP you will see him again, and you'll be able to talk about it with him again and try to make him less scared, even maybe together with a psychologist. So you have other possibilities, but you probably need to tell him. So even harmful information should often be told to a patient. So I'm going to a next example, and I probably would like to have your comments as well on this one. This is about the way that the fact that general practitioners, primary healthcare, at least in our country, always work with families. So this is about an example of a gentleman of 45 years old who lives in a small town, a very small town. I mean, I think in Indonesia, a small town is already if you have 1 million inhabitants. You know, Amsterdam doesn't even have 1 million inhabitants. So a small town for us is like, say, 20,000. It may be a village for you, but so let's say a village then. He was living in a small town. He was a very well-known, successful businessman in that town, or he still is, I think. And he was married. He had a son of 14 years old and a daughter of 12 years old. And he comes for a blood test for, I think, cholesterol or something like that. He wanted to know his cholesterol, but he always also asked the GP to do a more general test. So, and he asked his GP to do an HIV test. But he also says, if it's positive, and it was positive, so the blood test was okay, apart for the HIV positive test. And he tells the physician, when he gets the results, he tells him that he does not want his wife to know, and also not his children, because he is very afraid that being HIV positive will lead to maybe even to conflicts and maybe even divorce, and that it will become known maybe in the village or in the city. So he doesn't want anyone to know. So he tells the GP, I don't want you to tell it to my wife, and I am also not going to tell it to my wife. So maybe can we return to the because it worked well the first time. Can we return to the so the question now for the GP, maybe you could explain it a little bit also in Indonesian too. The question the GP said is, do I have to inform the wife or not? That was, in fact, the basic question. Who's also a patient of this GP. He's in the family.
Ya, silahkan Bapak Ibu apabila berkenan untuk berpendapat. Jadi pertanyaannya, apakah dokter sebagai dokter yang merawat akan memberitahu ke istri pasien tersebut atau tidak? Jadi di sini dokter ini juga merawat istri dan juga anak-anak dari pasien tersebut. Jadi sebagai dokter apakah akan memberitahu mengenai status HIV positif pasien tersebut atau tidak?
So
Belum ada yang raise hand, mungkin bisa langsung. Oh, ada Dokter Samuel Haryono. Silahkan dokter.
Ya.
Yes, thank you.
Ya, kebetulan saya punya kasus ya. Fortunately, I got a patient. This is a couple of a Japanese and the Japanese husband. Yeah, but anyway, I try to answer your questions.
Right.
Yeah, first, as a GP with who is responsible for the family history and the personal history, so I'm thinking that of course you have to be fair. I mean, you know better about the family situation, the relationship among them. If it will evac so far, I mean, so bad, getting worse, like getting divorced, I think I have to think it twice. But anyway, knowing that the husband got the HIV positive, what will the further harmful for the family. If it's really make it difficult, make it something in the clinical impact, I think gradually the the patient, I mean the husband, questions has to be answered. That the doctor has to be wise to inform the family, because my case, there has no they're positive there, but they went to every doctors, every this is a gynecologist, yeah, to gynecologist. This one is not HIV, HPV, but they have no effect, and most of the gynecologists inform we cannot do nothing. Even we know the strain, we know the virus, but we will not do anything. So, but the husband feeling so guilty, and the wife feels being so treated worse. But I try to understand, because the husband is quite honest, quite open. But this case, I think it depends on the situation. That's my comment. Thank you.
Thank you. Thank you. Does anyone else have a vision on this? Whether you should inform or not? GP has to tell his wife because it will affect somebody else's health, not only Mr. B, it will affect wife and maybe someone else. That's, I think, a very important point. Thank you very much. And then there's another one in Indonesian. Could you read that for me? Too? No. Tui.
Yeah. It's not them giving yet, but bisa dibaca. Oh. I cannot see clearly the chat here from here.
Oh, you can't see it clearly, so you have to get close.
I have it here, but now it's off.
Oh, it's off. So why don't you sit here then? And because I can read it, but I can't understand it.
Yeah. Oh, now it's on again. So here. So this is from Adelina Nababan. She said that according to her, we have to educate first the risk of being HIV positive and what the risk is for the family. And maybe if necessary, the education is not only once, but several times about the risk. And then it's to communicate that it is important for the general practitioner to tell the family with the approval of the patient.
Right. Yes. I think that's really true. And I think both answers are very helpful. So you can get back to the presentation now if you want. So both answers are really, all answers are really helpful, because I think the main ethical issue here is that Mr. B may be dangerous for his wife. So he may infect his wife, especially maybe also other people, but especially his wife. So, and that's really a question of really good education of the patient, to tell him that if he doesn't tell his wife, there may be severe consequences for her as well. And this is obviously what the GP who brought the case in said to the patient. So they informed the patient of the consequences of being HIV positive for their family members. But then the patient said, I'm very sure I will not give it to her, because I will protect, I will always be use preservatives, and we rarely have any sexual contact, so there's very little chance that we will have, that there will be an infection. But then when I discussed this in a group of GPs, the GP said, we cannot trust that, because it may still happen at some point. They may be, well, I don't know, that there may be occasions when he still will infect his wife. So you can't be sure enough. So then the GP said, you will have to educate him about that. And then, in fact, what the GPs say is that it is the responsibility of the GP to make sure that the wife knows, so that she also can take her precautions, and that she she can protect herself, or if she doesn't want that, then she knows at least that this is that this is going to happen. And so what the GPs say is you should really put the husband under pressure to tell it to his wife. So they were not going to tell it. The GP was not going to tell it himself to the patient's wife, because he said that's in fact breaking my secrecy, and I can only break my secrecy if I know that there's no other possibility, if I'm really forced to do it. But as long as the patient himself can do it, I'm not forced to do it. So what finally this GP said to Mr. B here is that he wanted them in a consultation together, and that he was going to be present while he was telling his wife that he had this infection. And then he said, so that may make it easier for you, and I can tell her the consequences and also maybe the reasons why. So that's what happened finally, and that persuaded Mr. B to tell it to his wife. So in fact, the doctor didn't tell it himself because he wanted to keep his oath of secrecy, but he did put more pressure on Mr. B because he felt that it was his responsibility as well. So that was, I think, a way out that would not damage the secrecy of the doctor, which is an important value, of course, for all doctors. It did not harm that, and it also took care of the responsibility for the wife and maybe other family members. And then a few months later, I heard from the doctor who had brought in this case that he had done that. So he'd asked and so Mr. B told his wife, and not the doctor, but the patient, and that there were no dramatic consequences. So he was very afraid that his wife would abandon him, but she had no intention to do that. And she was very happy that she at least knew what was happening. So this kind of issues occurs, and I think it's really important to keep up professional secrecy and at the same time follow the responsibility that you have for the family as a GP. So then, oh yeah, I'm doing this myself. So I'm going to the next. It's not working, I think. I'd like to have the next slide, but it's not coming. Yes, here it is. Yeah, I'll drop this one because I have. This is another one, another case that the family physician brought in our meetings, and this is about a 26-year-old man who comes for some common disease. It's not important. It may be a flu or something like that, but then explains why he really came. Because the flu he never goes to a doctor for. He knows it's self-limiting. But his real problem was different. And that was that he discovered the disease that his father had died from. Because his father, he knew that his father had died when the father was 33 years old, so he had barely known him. He was 8 years old when his father died, but he'd never known the diagnosis, never known why it was. And now his mother had told him what the disease was, and that was Huntington's disease. And as you probably know, this is a disease that could easily be transmitted to the son. There's a high chance that the son will also have the gene for Huntington's disease. And so that was 20 years ago. And the father has been cremated, so there's no remains of the father. And that was important because you can sometimes also see if for instance, a grandchild has the gene by comparing it with other genes that the father had, but they couldn't do that anymore. So now Mr. A says he finds it very difficult, but he has heard the symptoms of his father, and he also remembered that his father had very serious symptoms, and there's nothing to do about these symptoms. So he said, I don't want to know if I have it, because if I know that I have it, it will spoil the rest of my life, because I will always be afraid of having the same disease and getting the same terrible issues. And I think this is typically something that, at least in the Netherlands, would fall under the right of a patient not to know what he has. If they feel that knowing about the disease is more than they can bear and would make them very unhappy while there is no treatment for the disease, then it's understandable. Many patients don't want to know this. But now his wife is pregnant. So you may understand that he would want a prenatal test for Huntington's disease for his wife, for the child that will come. Yeah. But the problem is, if the child has the disease, then he will know that he has it too, because the child can only have got it from him. So this is the problem that he puts to the GP. It's quite complicated, but I don't know if it's, so he's extremely afraid, and he still wants it for the child. And as I told you, they can't get to the genetic material of his father because he has been cremated, so everything has disappeared. So the question of the GP now was, can I still do the test, the prenatal test, order the prenatal test for Huntington? Because his wife wants it. Could you explain that in, is it clear enough?
So the wife is also, with the same GP, right?
Sorry, what's the same?
The wife is also treated by the same GP.
Yes, they're a couple in the practice of, yes.
Bapak Ibu, jadi pertanyaannya yang untuk kali ini, apakah general practitioner ini tetap bisa melakukan prenatal test khusus untuk yang Huntington disease ini. Jadi karena istri Mr. A ini sedang mengandung dan kemudian istrinya ingin melakukan prenatal testing. Prenatal testing ini genetic testing, biasanya untuk mengetahui resiko terhadap macam-macam penyakit. Nah, sedangkan Mr. A ini tidak ingin tahu mengenai apakah dia itu memiliki Huntington disease atau tidak. Apabila dilakukan prenatal testing untuk Huntington ini, berarti dan hasilnya adalah positif, berarti Mr. A juga akan mengetahui bahwa dia itu memiliki penyakit Huntington. Jadi apakah dokter ini tetap bisa melakukan prenatal testing yang untuk Huntington disease? Silahkan Bapak Ibu apabila memiliki pendapat bisa langsung open mic.
Ya, kembali saya kasih komentar. Samuel nih. Pertama, right not to know tadi udah dikemukakan oleh Profesor Dick tentang right not to know. Right not to know itu bisa saja dilakukan, bisa saja tidak dilakukan tes. Setelah tes dia masih punya hak untuk tidak mengetahui. Dia tinggalkan begitu saja, suatu waktu dia siap, ataupun dia akan diwakilkan. Itu pertama persoalannya, right not to know. Nah, kedua, tentang perwakilan. Bahkan istilahnya bukan perwakilan, perwalian. Perwalian untuk genetik, untuk anak, genetik tes itu tidak boleh. Di barat diberlakukan setelah 18 tahun. Nah, ketiga, kasus ini prenatal test, bahkan bayinya belum lahir. Dan ini tergantung aturan dan budaya di sana. Di sana memang bisa dilakukan dan akan dibenarkan untuk aborsi. Nah, kasus ini juga teringat, kami mendapat kasus pasangan orang Belanda dengan orang dari suku kita Manado, sampai-sampai mereka tuh harus pisah karena trisomi dan anak itu harus digugurkan. Masalah itu tidak bisa diselesaikan, menjadi suatu polemik, dan kebetulan saya diundang, saya juga tahu siapa diri saya, artinya dalam hal ini saya harus menyampaikan posisinya di mana, karena si istri ini sampai-sampai minta cerai dan menganggap bahkan mertuanya dianggap setan, dianggap membantu merencanakan pembunuhan janin. Jadi kasus ini tergantung negara masing-masing. Kami nggak bisa menjawab karena di sana ada suatu tindakan lanjutan akan dilakukan medisinalis provocatus aborsi. Nah di sini kita kayaknya soal aborsi itu begitu ketat sehingga sulit untuk menjawab. Jadi mungkin jawaban yang terbaik itu mungkin boleh dilakukan, tetapi kembalikan kepada si ibu ini, apakah dia mau niatnya, tujuannya mau kemana? Apakah sudah dijelaskan lebih detail? Karena pre-genetic test, counseling itu lebih menjawab persoalan sebelum kita memberikan sikap boleh atau tidak. Terima kasih.
Terima kasih, Dr. Samuel. So again from Dr. Samuel. So the answer was we have to go back to the wife, his wife. What's the purpose of doing this prenatal testing? And then Dr. Samuel also looking from a bigger view, because it's also related a bit of what the regulation in this country is and how the implication is, because it might end up in a abortion of the child, or so there are wider consequences. So he thinks that asking first, what's the purpose of the genetic test? Right.
Yes. I think that's a very important remark. I'm happy you raise it, because I hadn't put it in, because I think that's really the first thing that you have to ask. Why does your wife want the test? Why does she want it? In this case, it was clearly the case that if the child would have the Huntington gene, then the wife would want an abortus provocatus. So she would have want an abortion, and legally speaking, in the Netherlands, that is possible. So if she would have wanted that, she would have got it. Especially if you have this. I mean, that may be legally different here. I'm not sure. Is it? How is it here? Would they be able to get that or not?
As I know, not.
No. Okay. So that was the reason to do the test. So I think most people in the Netherlands would not object against that, because it's become common practice, and many people find that if you're early enough in pregnancy, so it has to be very early in the pregnancy, then you can still do an abortion, maybe because some people think that many pregnancies will stop anyway, so it's not that difficult. But if it's later on in the pregnancy, then it becomes more difficult. And so that's very important. But this was the reason for the wife. And for the GP in the Netherlands, that was not a reason, that was not something difficult. He would, in principle, agree with this. But then there's another issue. And I think that's very important to keep in mind if you have this kind of problems. And I think that was made a lot of sense. One of the GPs in the group said, if you refuse the prenatal test, so that the pregnancy will go on and the child will be born, how will that be for the father? Because then there will be a child who may have Huntington disease, and you don't know if he has it. And so that will have the same consequence as knowing it for him, because he would be very afraid that his child would have Huntington's disease, because he could have given it to the child. So what this GP proposed is that you have to speak with the patient about the consequences of not doing the test. And the consequence of not doing the test would be either abortion without knowing if the child had the Huntington disease, so an abortion, because the wife could also say, I'm going to do an abortion if there's no test, because she would feel that it's too hard to have the risk of a child with Huntington. So that would be the alternative, I think, for the patient. So what this doctor finally did, and I think it was very wise to do it this way, is that he also had a consultation with the wife and the man, and then he explained to them what the consequences of the both options would be. So probably if there would be a prenatal test and the child would have the gene, then there would be an abortion. But also the man would know that that was the case. But if there would be no prenatal test, then there would probably also be an abortion because the wife didn't want to continue a pregnancy that may lead to a child with Huntington or had a high chance. So it would not change very much. In both cases, probably the wife would want abortion. And Mr. A was very happy with the pregnancy, so he didn't want that. So he finally chose for the prenatal testing. So he said, yes, if you, now that he knows all the options, he said, I prefer to do the prenatal testing, even if that may cause a lot of suffering for me, because I know that I will get something so serious. And so finally that would happen. That's what happened. And this is for once a story with a happy ending, because the result of the prenatal testing was that the child didn't have the gene. So the father may still have it. That's not excluded, but at least he still doesn't know. So he's in the same position, but he knows that his child will not get Huntington's disease. So that was a really happy ending for them. So this is, an extreme, Huntington is an extreme example of how the knowledge for one part of the family, even an unborn part of the family, may have consequences for others in the family. And Huntington is a very extreme example, so it's very good. You can explain clearly what this kind of consequence is, but in fact, for every genetic test, it may have consequences for the family. That's something I think that GPs begin to realize, and it may cause ethical issues if the family doesn't want that. Okay, so any other comment on this case? Because I have a few more in other. How long do we have, Pratiwi?
So 30 more minutes.
30 more minutes?
Yeah.
All right. I'll see if I have to jump to some other thing.
Or
No, that's no problem. I prefer. Because otherwise it's too long for everybody. Now, this one I've had, now it jumps back. Oh yeah, this is the one. One of the issues that many GPs in the Netherlands have trouble with, ethical issues about, is the role of insurance companies in healthcare. I don't know if the same occurs with physicians in Indonesia. I do think so, because we've been speaking about that in your study also. Physicians complain about that. So what they complain about is the interference of insurance companies in their care. So sometimes GPs have to refer a patient because of insurance reasons, or they may not refer a patient because the insurance thinks that it's too expensive. So I will present you an example that one of my colleagues gave me, and it's about a Mrs. Patil. She was it's another name, but it was a 46-year-old lady who was originally from India. We have a very small Indian population as well in the Netherlands. We have a lot more Indonesians, but Indians a few. And this 46-year-old lady was seriously overweight. And that is partly due to the antipsychotic medication that she needs for periods of schizophrenia. So she really is a very complex patient. Already, she doesn't speak Dutch almost. She almost doesn't speak English. And she has this psychiatric condition. And then she has overweight. And so because of the overweight, she has developed diabetes mellitus type 2. And she is treated with insulin. The insulin has been started by an internist, by the specialist doctor, but is now monitored by the general practitioner. And as I said, she speaks just a few words of Dutch and a very little bit of English. And it's clear that she does not really understand the disease. It's quite difficult, and she is forgetting her insulin very often, and she doesn't have a family that keeps an eye on her. So, in fact, she is really difficult to regulate and to monitor. So she has a high HbA1c, which is, as you know, probably the best indicator of the regulation of the diabetes. Now, the ruling is that the insurance only pays for the treatment by the GP if the GP succeeds for patients where HbA1c is under the established limits. And Mrs. Patil is above the limit. So the insurance will not pay him because of the outcome. But on the other hand, the GP has a lot of conversations with the patient, and he knows that there's no way that she will do better. So then what he would have to do for the insurance is to refer Miss Patil to the internist, and it's medically unnecessary and it's more expensive, but it's desirable because otherwise he will be forced to work for free. So the insurance will not pay his care. So that's a difficult situation for this GP who just wonders. And then he put this case to the group and said, is it ethical to refer her even if it is not medically necessary? So as I told you, one of the central values of general practice in the Netherlands is not doing too much, also not too little, but not doing too much. And he felt that to refer her to the internist would be doing too much. So the question is it ethical to refer her? Or should he go on treating her without being paid? So that was the issue that was raised. Maybe we could try and see if there's anyone who has any comments, and then I'll tell you what the outcome of the group discussion was that we had. Because this is really a conflict between the values of the GP, the value of not providing unnecessary care, and on the other hand, also being able to continue to perform the care financially. So is there any remark maybe from the group?
Silakan Bapak Ibu apabila memiliki pendapat. Jadi dengan situasi pasien yang HbA1c-nya di atas batas, jadi lebih asuransi tidak akan mereimburse atau tidak akan membayar perawatan yang dilakukan oleh GP. Sedangkan untuk referral ke penyakit dalam itu secara medis memang saat ini tidak diperlukan, tetapi mungkin secara finansial itu akan lebih baik karena nanti akan bisa direimburse oleh asuransi. Kemudian pertanyaannya, apakah hal ini etis untuk merefer ke penyakit dalam atau bagaimana pendapat Prof, Bapak, Ibu? I will check in the chat, not yet. And not also from
Okay,
the
so
audience. Yes.
maybe then, yes. So maybe I'll just explain how we discussed about this. But so in the group discussion, there was more talk about how, so why would you not refer her to the internist? And one of the reasons why the GP said he would not want to refer her is because she also had this psychiatric condition, and that it might be very, very stressful for her to go back to the internist and to go to the hospital, because she had been psychotic after earlier visits to the hospital as well. So she was, in fact, a very vulnerable woman who was barely able to understand what happened around her. So he said he felt bad about referring her to the internist, because in fact, after the referral, she would have to be treated by the internist continuously, because the GP would not be paid for the care that he delivered to her. So finally, what the group said is, if you have so much objections against referring her, then either you have to call the insurance and ask if they would make an exception in their rules for this particular patient because she has all these issues, or you have to not refer her and keep taking care of her even without reimbursement. And finally, I think that is what the GP did. He tried to get the insurance to pay for the care because of his arguments that referral for this patient was really not a good idea. And but the insurance continued to refuse. So they said, we're not going to make any exceptions here. And insurances are not very willing to refuse. And there's also a little bit of problem of obviously of secrecy here, because the GP said, I don't know what exactly I can tell about Mrs. Patil to the insurance, because if he tells a lot about the psychiatric background of his patient, that's not something the insurance is entitled to know. So he was also in trouble. So he didn't tell a lot, but he just said, I know I have good reasons not to refer her. And could you please make an exception? And then the insurance said, no, we're not going to make exceptions. So finally, the group and also this GP said he was not going to refer because he felt that it was too burdensome and too difficult for the patient to be referred. And he found that it was unethical. And then he continued to treat her even though he wasn't paid. So I think that finally is a solution that you come to. And as long as this doesn't happen too often, and obviously she was quite a complicated patient. It's not a bad, it wasn't something bad. So it was, I think, a good choice finally. But and I think the most ethical choice. And that's what also the GP who was concerned thought, that it was the most ethical choice. All right, I will come to almost my a next group of people. And I'm not talking so much about very demanding patients, but I'll just show you an example from our ethics group discussions about a self-neglecting patient. So you must know those people here as well. They're what also sometimes is called the care avoiders, the people who never come even though they are diseased and who avoid doctors. So I'll give you an example. This is the room of a care avoiding patient. So It's not this particular patient, but it's a picture that one of the GPs took of, with the consent of the patient, of the home of one of his patients. This is a Mr. Visser, is typically Dutch name, it means fisherman, who is 47 years old. He lives alone, and he's always been quite a strange and solitary person all his life. Now he has moderately severe COPD, but he does not want treatment. And he also does not want to stop smoking. So he really chain smokes. It's something like 2 packages a day. And that's what he spends most of his money on, because smoking has become obviously very expensive. And then he has had a shop in secondhand gramophone records and magazines. And that shop has obviously made bankruptcy because he wasn't able to do that. And now his house is full with the gramophone records and his magazines. So it's really very difficult to go in. And I don't know what that says, but there's almost no living space. I couldn't read it because of the camera. So that's the condition this person lives in. Yes, that's what I would, yes. So the GP, and that we sometimes do home visits. We often do home visits, but sometimes we do home visits to people. And this GP had the habit of visiting him 2 or 3 times a few years ago. But then when he rang, because he had heard from others that he was living in a difficult condition, and because he has this chronic disease, he felt responsible to go there from time to time. So, but he was always refused. He refused. So the door was opened, and then Mr. Visser was very friendly, but he always said, no, I'm not going to let you in. And but he also said, it's such a mess. I really can't let you in. That's too much of a mess. I have to clean up first. So please come back next week. But next week it was the same story. He still hadn't cleaned up because he didn't know how to clean up. He had no idea. So then finally, a month later, again, the same thing happened. And then the GP said, I don't mind. It's a mess in my own house. I don't mind. But still, Mr. Visser didn't want. So then the GP decided to leave him alone and not go and not monitoring his COPD, which he usually would have done with a patient who was accepting his care. He would have, let's say, appointments every 3 months or every 6 months to monitor the progress of the chronic disease. But with this patient who refused a few times, he decided not to go along. And then a few years later, so we're now a few years later, he gets a letter from the hospital saying that Mr. Visser has been admitted to hospital with a severe exacerbation of COPD. So he was really in a very bad condition. And he was severely underfed, as is often the case with people with COPD, as you probably know. They tend to eat too little because takes too much breath to eat, in fact, and with self-neglect. So then this GP felt a bit bad about his decision not to go and visit the patient regularly, because he thought he might have prevented the exacerbation and might have also done something about the underfeeding, which in turn also made the COPD worse. So his question to the group there was, should I have monitored the patient even though he repeatedly told me that he didn't want it? So should he still have monitored the patient? I don't know if anyone wants to say anything, so please do if you want, please. Or will you explain it in bahasa again?
Ya.
Yeah, right. Okay, good.
Ya, silahkan Prof, Bapak, Ibu, apabila ingin berpendapat, bagaimana seharusnya dokter yang merawat ini? Apakah seharusnya dokter ini memonitor pasien tersebut meskipun pasien ini telah menolak untuk dilakukan monitoring dan dilakukan home visit?
That was nicely brief, isn't it? Very good. So I don't know if anyone wants to say something. There's something in the chat, or is that an old chat? I see
Silakan
two
apabila
chats.
ada pendapat.
Could you show the chats? Oh yeah, they're far away. Yes, Steve. Oh no, that's the prenatal test. That's the last one. Well, maybe I can come back.
Atau mungkin Mbak Galuh.
That's interesting. I'd like to come back to this chat.
Ya,
Because yeah. We'll get back to the other patient later. Someone, Mohammed Arif says he still has to do the test, but he doesn't have to tell the patient, and his wife also should keep the information to herself. That sounds like a very good solution, but I'm afraid it's not a solution, because what will happen is that the test will be performed, and Mr. A will always know what the result was, because if there is no abortion, then he knows that the child didn't have it. But if there's an abortion, then he knows that the child had it, and then he knows that he had it himself. So, and you know, this is not stupid at all. I mean, everybody has this idea, just doing the test and not telling Mr. A. But in this situation, it's impossible to do that, because he will know that the result of the test from the consequences of the test. So the test has two possible consequences, and then he will infer the result of the test, and then he will know that he had it himself, or that the baby doesn't have it. So those are the two things that he will know. But I'm glad, I'm very happy that you raised this, because this is something that that most people raise, and you know, I think very often. What's that, Agnes? What do you? Oh.
Yeah. I know. I'm just saying if someone wants to have their opinion.
Yes. Yeah. So and I think that's very often the case. If someone doesn't want to know the result of a test of a family member, then they can very often infer later through the consequences what the result of the test was. And so they will know whether they have it themselves. So thank you for that comment. It's really good comment, even though it's not really a solution for the problem. So can we get back to the COPD? I'll if there's no one who wants to comment, I'm happy to continue as well. So this was, and I think in the discussion, many people said that they would have done exactly the same, because being refused, even friendly, 3 times is a good indication that someone really doesn't want this. And you still may feel responsible, and you may feel that you would want to monitor your patient and prevent severe exacerbation, but being refused 3 times may be enough. Now, some people raise the issue of mental competence here. So they said, is it sure that Mr. Visser is mentally competent to decide not to let the doctor in, or not to come to visit the practice? And that's something that's very difficult to decide sometimes, because obviously you maybe should do a test about competence, so see if he understands everything. But that's very difficult if you can't get in. So if you can't communicate with him, it's very difficult to know whether he's mentally competent or not. And we have a rule that if you have no indication of mental incompetence, you have to you have to consider the patient to be competent. So in doubt, always consider the patient to be competent. So in this case, it's difficult to say that this patient was not competent. And then someone also raised the issue about what would happen if, for instance, Mr. Visser had a son or something. I'm not sure if he had children, but if their children would come along and say and sue the doctor because he had neglected their father, that's also a possibility. So some doctors say, well, I would be very afraid of accusations of neglect. So maybe they would go there regularly to be refused anytime, but then at least they couldn't be accused of neglect of the patient. But that, I think, is a very negative reason to do it. But it may happen, of course. So what we always say is that if you take an ethical decision like that to leave someone alone who might in fact need your care because that person keeps refusing it, then maybe you should discuss that with your group and make it a decision that you didn't take all on your own. And I think that's a lesson for many GPs in the Netherlands who tend to work alone in their own practice. So decisions that have a lot of ethical aspects or ethical difficulty are decisions that you really should try to share with colleagues and discuss with colleagues so that you can show that you also, if only to show that, and they may have good solutions, but it also shows that you did do it carefully. So that was, I think, enough about the, can I get to the next one? Enough about the, I'll stop, I won't do this. Maybe I'll get back to it because I would like to end with the very modern patient. The patient who's consulting not only his GP, but before everything, what we call Dr. Google. So who's Googling about the complaints that he has. And I think that happens here as well, doesn't it? Yeah. So patients increasingly consult internet sites, any types of internet. They just type in their complaints in Google, and then they get a lot of advice and things like that. So often GPs say they already have decided which investigation they need or which referral they need before they go to see the GP. So they come with a list of, like if they go to the grocer, they have a list of things that they want to have referrals for or forms for. And there are also increasingly people who consult Dr. Google and then don't even ask their GP if they need the test, but go straight to the private laboratory. And they get MRIs and blood tests without even a consult. And that's, for many GPs, consider that a very bad idea because it's difficult. I mean, they have had 6-7 years of medical training to decide which investigation is needed in which type of complaints. And then patients now do that all on their own. So I have an example of that was also brought in by one of my colleague GPs. And that's the last example I'd like to show you. So could I, oh no, I can do that myself. Again, of course. This is a gentleman, I think he was about in his 40s as well, who has a recurrent headache and who himself thinks that it may be related to work stress. So he's had a lot of work and he's overloaded with work. But then he says, I'm here because my wife is so concerned. And she's very afraid that it may be a brain tumor. So that's what he says when he comes in. He's in fact excusing himself a bit because he says, I think I know what it is. I think it is work stress. But, and his wife, especially, he didn't do that much, but his wife consulted various internet sites telling her that MRI is the gold standard to know if there's a brain tumor or not. So he says to the GP, can I get an MRI to make my wife less worried? And of course, the GP here too knows the wife. And he knows that she is always very worried about her health and about the health of her children and her husband. But still, he has difficulty here because he wants to follow the guidelines that the Medical Association has set up about recurrent headache. And that guideline is very clear. If there's no alarm symptoms like sensory problems or let's say paralysis or that kind of things, then there's really no reason to do an MRI. So and there is a danger in doing an MRI because they may discover things that shouldn't be treated, but that will then be treated. So it's also not without danger to do MRIs unnecessarily. So the GP prefers to follow the guideline. Now the question is, should he consent and refer for the MRI to make the wife less concerned? Or should he try to convince Mr. Y himself, not to do the MRI and find another way to alleviate the concern of his wife? So maybe you have a last chance of saying something on this case, which is, I think, a regular case in Indonesia as well now, this kind of cases. So could you say a little bit? Yeah.
My microphone on ya? On ya. Silakan Bapak Ibu apabila akan berpendapat mengenai hal ini. Jadi apa yang seharusnya dilakukan oleh general practitioner yang merawat ini? Apakah dokter ini perlu memang untuk melakukan MRI sehingga istri pasien tersebut tidak menjadi khawatir karena istrinya juga pasien di dokter GP ini, atau lebih baik dokter ini meyakinkan pasien ini, Mr. Y, bahwa MRI ini tidak perlu untuk dilakukan. Silakan Bapak Ibu. Maybe in the meantime, from the previous case,
right.
maybe because they need maybe some more time to think, so I can read it. So
yes.
Firstly, what's the reason actually why patient decided to refuse the GP's visit? Practitioners have to respect for autonomy patient, but respect for autonomy doesn't mean the one and only choice. What's patient preference depend on his visit or maybe the other practitioners patient wants.
Yes,
yeah.
Right. Yeah, I think that's a very good completion of the other case, because it's very important to explore the reasons why this patient didn't want to have the doctor and didn't want the visits, because this physician thought it was because the house was a mess.
Mm-hmm.
But maybe there were other reasons. So it may also be that he wanted another practitioner. It's really very well possible. So it would be maybe a good solution to propose that to the patient and say, I can also send someone else if that's what you prefer to do. Thank you very much for that idea.
Yeah. This was from Desi Putri.
Yes.
And then now from Muhammad Arif Aminin. Mr. Y, GP must follow guidelines, not patient or patient family, but give education to patient and family about the disease symptoms and signs, especially warning sign of brain tumor.
Right. Thank you very much for that comment, because I'm really, this is what we discussed with the GP. So, and the GP was very happy with the advice of the group then, because the group said, you shouldn't refer someone to have an MRI while the problem is in fact the concern of the wife. So you shouldn't have him go through MRI because the wife is so concerned. If he has no concerns for himself, then why would you, it's not a good idea. So what the group advised this GP to do, and that's an advice that's often very good, is to also invite the wife in the consultation room and to explain to both of them why he thinks that it is a recurrent headache that may be maybe completely related to work stress, and that there are no symptoms that need an MRI. So explain also to the wife that what the reason is that you don't think an MRI is a good idea, and what you also should do, I think, is actively offer monitoring. So, and that's also what this GP found a good advice. So what you say is that at the moment, I'm really convinced that it is work stress and that we should do something about the work stress, but we will keep an eye on the patient for the next year or two and have regular contact about how the headache is going. And through this, and always do the consultation with the two if the patient consents with having his wife present. But I think that's the best, and I think it was in your comment. So you should explain not only him, but also the family. Because I think very often in general practice, but also in specialist practice, we tend to forget that there's always people behind the patient who are concerned or who want specific things and who hope that the patient will be referred or that he will get medication, or so there's always a family behind the patient. And that's why it's so important to look at primary healthcare as a form of healthcare that takes the family as a unit of care, and not only the patient, but always ask and explore what the family thinks about things. So thank you very much for that answer. So I will be concluding now, if I can get to the next. Can I? Yes. So I think the conclusion really is that primary care has ethical problems that are to some extent different from hospital. And that has to do with the basic values of primary care that I showed in the beginning, which are related to continuity, to cooperation, to personalization, and to the fact that the family is an important element of the care. And they are more related also to chronic disease and also to palliative care, but I haven't talked about palliative care because we will do that tomorrow. So I haven't done that now. And it's related to patient self-management, including what patients do with Dr. Google. And I think that nowadays, almost every patient who comes has been consulting some form of Dr. Google to some extent. And I think ethical problems may become more serious because of the increasing role of insurance companies in monitoring the outcomes of medical care, which has influence on the autonomy of the doctor in the consultation room. So I think I had one more. That's it. So I thank you very much. Terima kasih for your attention and for staying so long. Incredible. We still have more than 30 people. I'm really, really impressed with that and happy about it. Thank you very much.
Thank you, Pak Dik.
Ini on
Thank
apa
you,
enggak?
Rama. If that was, I don't know who it was.
Terima kasih Bapak Ibu. Ini
That was Rama. Thank you.
terima kasih Bapak Ibu atas kehadirannya. Ya, ya maybe untuk besok dan berarti besok Kamis dan Jumat kita akan ada simposium palliative care yang juga bisa dihadiri Bapak Ibu secara online. Informasinya ada di chat dan mungkin bisa menghubungi kami apabila memiliki pertanyaan lebih lanjut atau akan mendaftar. Kemudian maybe I have also some takeaways from this presentation
good.
because this a very nice explanation about the ethical issues, and some are similar, some are different with the Indonesian context, such as the role of health insurance, the national health insurance that we have here, which also from some of my colleagues also they interfere, the regulation interferes with the autonomy of the doctor and how to still provide a good care around this regulation. And then it's really interesting to know how close the general practitioners are in the Netherlands to the family. So even though the patient is the center of the care, but the family are closely around that. And here in the Indonesian context, we see also that family is really close, but it usually comes at the end when making a decision.
Right.
So then the family will have to say something, or in some cases or in some cultures, even not the patient, but the family will make the decision. So there are some similarity and difference which are very interesting to know. And also about the genetic testing, it's quite advanced, which we don't have yet the ethical issues here. I think the general practitioner, but maybe in the future we have also these issues. And the Dr. Google, of course, I think almost every practitioner has faced the same issue.
Yeah.
Terima kasih banyak Bapak Ibu atas kehadirannya dan juga partisipasi dalam diskusi baik melalui chat maupun langsung. Mungkin kami tutup Rabuan pada siang hari ini, dan kemudian untuk Rabuan selanjutnya siapa ya? Informasi mengenai Rabuan selanjutnya juga akan kami berikan kemudian.
Thank you for your presence.
Baik. Untuk Rabuan selanjutnya kita akan pembicara kita adalah Dr. Paramita Sari, MSc, alumni program studi Magister Bioetika mengenai sikap dan respon tenaga medis terhadap keterbatasan alat pelindung diri atau APD selama pandemi COVID-19. Terima kasih Bapak Ibu, dan kami mohon undur diri, kami mohon maaf apabila ada kesalahan dan hal yang kurang berkenan pada sesi Rabuan kali ini. Terima kasih.
Terima kasih Mbak Tiwi, terima kasih Pak Dik.
Romo, apakah hadir rawuh besok, Romo?
Hadir besok.
Pleasure. Thank you very much.
Beberapa mungkin bertanya-tanya di mana Prof Yati dan Prof Narto. Beliau hadir di studio pada siang hari ini.
Is this Prof Romo speaking? Or not?
Yeah.
Okay. Really nice. Yeah, really nice.
Yeah, Prof Dik. I will come tomorrow, but a little bit late.
Okay.
Because I have to teach before.
Yes, of course. First, I would say. Really, yeah. Yeah, but I'm happy. I'll be happy tomorrow to see you.
Okay, thank you.
Yeah. There are 2 more chats there.
Chat says just it's thank you.
It's thank you chats.
Thank you, chat.
Well, it was my pleasure. It's very important, but it's my pleasure. Yeah.